Are you gearing up for radiology board exams? The Radiology Review wants to save you money. Visit our discount code section for current offers on Radiology Review recommended educational resources. Head to theradiologyreview.com and navigate to the discount code section. Terms and conditions apply. Limited time offer. Discounts may vary. Welcome to the Radiology Review podcast with your host, Dr. Matt Covington, a board-certified radiologist. For additional content, please follow the Radiology Review on social media, such as X or Instagram, at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website, theradiologyreview.com.
I am Dr. Covington, and I want to welcome you back to the Radiology Review podcast. This episode focuses on the non-interpretive skills section of the core exam, and in this episode we will discuss questions and answers pertaining to imaging informatics. Now, as a reminder, the American Board of Radiology does issue a non-interpretive skills study guide, and this is based on content in the most current 2024 version as of this episode. Please refer to the most current version of the ABR Non-Interpretive Skills Study Guide when you are preparing for the core exam to both check the accuracy of the content which I have here, despite me doing the best I can to be accurate, as well as to make sure that the content you are reviewing is the most up-to-date. A link to the ABR's Non-Interpretive Skills Study Guide will be provided in the study guide, which you can download for free on my website, theradiologyreview.com, where I will have the questions and answers reviewed in this episode available in writing. So please check this out at theradiologyreview.com if that is helpful for you. And while you are there, also check out the discount code section on my website, where I frequently have various discounts on radiology education and board review materials. And without further ado, let's get into the questions and answers for this episode. First question. What is the DICOM standard, that is DICOM, and what are its primary functions in medical imaging? DICOM stands for Digital Imaging and Communications in Medicine, and the DICOM standard is an international protocol used for the display, transfer, storage, and processing of medical images. It encompasses both pixel-based image data as well as metadata, which are stored in the DICOM header of each image. DICOM enables organized querying, retrieval, and transmission of data between systems and facilitates the transmission of order information as well between the Radiology Information System, which is frequently abbreviated RIS or RIS, and the imaging scanners themselves, such as a CT, MRI, or ultrasound scanner. This DICOM information reduces the risk of data entry errors. Next question. What type of information is contained in the DICOM header? The DICOM header contains metadata about the medical image. This metadata includes patient information such as the patient name, patient ID, date of birth, and gender, study information such as the study date and time, study description, the referring physician's name, series information such as the series number, series description, and the modality such as CT, MRI, or ultrasound, image information such as the image number, image type, the acquisition date and time, scanner information such as the manufacturer of the scanner model, the device setting information, and the facility information, including the location and name of the imaging facility. This organized structure of the DICOM header allows for efficient querying, retrieval, and transmission of medical imaging data between different systems. Next, what is HL7? How does the HL7 standard facilitate the exchange of medical information, and what are its main versions? HL7 stands for Health Level 7, and it is an international standards organization responsible for developing standards for the exchange, integration, sharing, and retrieval of medical information, excluding image data. The HL7v2 messaging standard is currently the most widely used healthcare-related standard worldwide, and this enables interoperability between different electronic medical systems. Although HL7v3 is more human-readable, it is less commonly adopted due to its complexity. The HL7 Fast Healthcare Interoperability Resources, which is abbreviated FHIR, is a newer protocol that allows the use of internet transactions to exchange medical data between systems, enhancing the potential for seamless data exchange. That is a lot of information. Please review this in writing to solidify this, and let's go ahead and move on. Next, what is RadLex? That is RADLEX. And what is its significance in radiology? RadLex is the largest radiology-specific lexicon and contains over 68,000 terms pertaining to imaging anatomy, procedures, and pathology. It is an ontology, which means it organizes terms and their relationships. The RadLex playbook standardizes imaging exam names, descriptions, and codes. This playbook merged with something called LOINC, which stands for Logical Observation Identifiers, Names, and Codes, which is the international standard for health measurements and documents, enhancing the standardization and interoperability of radiological data in medical systems. Let's go ahead and move on, and I think you're sensing a general theme by now that things like RadLex, HL7, and DICOM are all standard ways of documenting, entering, storing, and transmitting medical information, and in this case we're talking about things pertinent to radiology and other medical imaging exams. Next, what is a PACS system? That is PACS. I assume you all know that. What is a PACS system, and how does PACS support radiologists in medical imaging? PACS, which stands for Picture Archiving and Communication System, serves as the primary tool for radiologists for image viewing and interpretation. PACS consists of essential components such as displays, workstations, short-term storage, and long-term archiving systems. PACS interfaces with imaging modalities through DICOM transactions and communicates with radiology information systems, the so-called RIS or RAS, and or the electronic medical records system using HL7 transactions, which are translated to and from DICOM. Unlike early versions that require dedicated physical workstations, modern PACS systems are web-based and accessed by mobile devices and desktop-thin clients, and that enhances flexibility and accessibility for radiologists. Next, what is the Vendor Neutral Archive, sometimes abbreviated VNA? The Vendor Neutral Archive allows for centralized storage of data supporting various DICOM image types and non-DICOM data like photographs and pathology slides. Enterprise imaging utilizes VNA technology extensively to streamline the sharing, viewing, and storage of medical imaging data across various departments beyond radiology. However, a significant challenge lies in standardizing the formatting and exchange of metadata. For example, patient and imaging details and acquisition date, accompanying non-DICOM images within enterprise imaging systems. Next question. What does RIS stand for, RAS, and what does RIS do? RIS stands for the Radiology Information System, and this is software that manages imaging exams, order reconciliation, scheduling, communication with various scanners and PACS, reporting, results notification, and billing. RIS can operate independently or integrate as part of the electronic medical record. So essentially, these RIS systems are involved in the imaging chain from beginning to end and help with each step along the way. Next, what are key factors of the ACR, AAPM, SIIM technical standards for reading room lighting and diagnostic monitor luminance? There are definitely a lot of abbreviations associated with imaging informatics, and in this one, the ACR, AAPM, SIIM technical standard suggests that optimal ambient lighting in a reading room should range between 25 to 50 lux, which is similar to standing under a streetlight at night in dark conditions. For diagnostic monitors, the standard recommends a minimum gray value luminance of 350 candela per square meter, which is often written CD/M2 candela per square meter for non-mammographic interpretation. And if you are interpreting screening mammograms on a diagnostic monitor, you need to increase the minimum gray value luminance from 350 up to 420 candela per square meter for mammographic interpretation. Next, what is the difference between lossless and lossy image compression for image storage? Image compression is used to lower the storage requirements of radiology images. Lossless compression removes portions of the image which are redundant and not important for medical imaging interpretation. For example, lossless compression may remove the black background on a CT image. Lossless compression currently allows image file size to be reduced by about 3:1. On the other hand, lossy compression removes redundant as well as so-called minimally important image information, with the goal to preserve as much diagnostic quality as possible. Lossy compression can lower image file size by about 10:1. Next question. What are 3 classic repetitive strain injuries radiologists are susceptible to due to work conditions? Due to the many long hours at a computer workstation, radiologists are prone to repetitive strain injuries, which are sometimes abbreviated RSIs. 3 classic repetitive strain injuries that radiologists are prone to are carpal tunnel syndrome, which involves the median nerve, cubital tunnel syndrome, which involves the ulnar nerve, and de Quervain tenosynovitis, which involves the thumb. To minimize the risk of repetitive strain injury, proper workstation ergonomics should be assured. Next question. What are key workflow steps from imaging order to issuing the imaging report? Key workflow steps to get from ordering the imaging study to receiving the imaging report include: first, an order is placed in the electronic medical record. Second, HL7 transactions communicate the order to RIS. Third, RIS communicates the order to the scanner via the DICOM modality work list, and the image is obtained. Fourth, the scanner communicates with PACS via DICOM transactions to transfer the image. Fifth, a radiologist views the image on PACS and dictates a report, typically with voice recognition software. And sixth, the reporting software sends the report to RIS and the electronic medical record, again using HL7 transactions. Next question. What is the difference between disaster recovery and business continuity procedures? Disaster recovery and business continuity procedures are both part of the downtime procedures of a radiology workflow. Disaster recovery procedures come into play, as the name suggests, in the event of a disaster, and become particularly useful in highly disruptive disasters. Disaster recovery procedures include establishing in advance of a disaster how off-site data backup systems will be managed, including how often data will be backed up, and the steps necessary to restore critical data if a disaster or other disruption occurs. On the other hand, business continuity procedures are those procedures necessary to continue to care for patients when a system failure occurs under non-disastrous circumstances, such as a routine power outage. Business continuation procedures also specify policies to follow, including backup requirements, so there often will be some overlap between disaster recovery and business continuity procedures. Last and final question for this episode. What does it mean that radiology systems need to be so-called high availability systems, sometimes abbreviated HA? High availability systems must be able to withstand service disruptions by having in place automated recovery and failover operations if a service disruption occurs. There is a so-called number of nines expectation for high availability systems, and for radiology, the American Board of Radiology states that PACS, for example, is expected to achieve 4 nines of uptime, meaning it is functional 99.99% of the time. Interestingly, per the ABR, this means that PACS should have no more than 50 minutes of downtime a year. To achieve this level of reliability, the system needs high fault tolerance, meaning functionality will continue if single components of the system fail. This requires redundancy within the system components, such as redundancy in servers, storage archives, and network connections. And that concludes part 1 of my review of Imaging Informatics for the Radiology Core Exam. Again, please make sure to download and study the ABR's most current version of the Non-Interpretive Skills Study Guide. And you can also download my own study guide for the content specific to this episode at theradiologyreview.com. The ABR's Non-Interpretive Skills Study Guide can be downloaded through the ABR website, and a link to that will be available on my study guide, or obviously you can find it through Google. I hope this content was helpful for many of you. My non-interpretive skills episodes to date have been some of the most requested and listened to episodes, and I hope that this continuation will be helpful to help expand review, learning, and comprehension of this topic. So keep up the good work and study hard. Remember, you have to study really hard to succeed on radiology board exams. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.
The Radiology Review is pleased to offer the Board Exam Study Guide, episodes 1 through 101, available for purchase as a book on Amazon or in Kindle version.